Hey y'all, I'm Dr. Reagan and welcome back to CRxOWN Talks, your dose of health and healing in Black communities. And in about 15 minutes or so, we clear up myths about Black health and break down the healthcare questions you wish you'd asked and the ish they should have told you. Now today I'm joined by Dr. Christina Madison, the public health pharmacist, and we're about to break down my favorite subject, HIV prevention for Black women. And we're going to drop in how the healthcare team can really help us. Dr. Madison, hey.
Hey, how are you? I'm so excited to see you, Reagan. We just saw each other in person in December, but I always love seeing your cute smile. Like you exuberate just all this joy and hopefulness, and it just makes me smile every time I would see, one of your new podcast posts. I'm like, I need to be on that podcast. And so I'm so glad that, I reached out and you were like, oh, I was trying to reach out too. So I'm just glad this all worked out, because this is also a topic that is near and dear to my heart. We both woke up Black today.
Right. Yes. I love you so much. So thank you. So let's jump straight into the rundown. So I want to get into this public health pharmacist. I want to know kind of what inspired you to be the public health pharmacist and why sexual health?
I mean, ultimately, because I saw so much happening within our community and such a lack of health literacy when it comes to being able to protect ourselves and to be able to have the sex lives that we want. And I think ultimately, because of societal's need to hypersexualize Black women, it really puts us in a very difficult position when it comes to being able to protect our own sexual health and wellness, because ultimately we're seen as these sex objects, but then we're not being asked for consent, or if we do get consent, we're not taught how to negotiate, how to use barrier methods, because often that is the responsibility of the partner, especially if it's a male partner. And so for me, it was really, I wanted to give back to the community that gave so much to me. And I saw this really unmet need, specifically in the Las Vegas community, because sex sells. That's what Vegas is known for: sex and gambling and good times. And so for me, I distinguish that you can have the sex life that you want and you can have that sexual freedom, but you need to be able to do it safely. And if that's not through a barrier method, we have agents that will help us to be able to prevent getting these sexual transmitted infections, such as HIV, as well as bacterial STIs like chlamydia, gonorrhea, and syphilis, which we know are drastically impacting the Black community, especially as we see a rise in congenital syphilis cases. So for me, it is a passion. It is a cause. It is something that I wake up thinking about. How can I protect my sisters? How can I protect my community? And how can I stop the spread of HIV?
Okay, so that was a perfect answer. And one of the things that really, really resonates with me is this idea that sex and sexual health prevention has to be absent of good sex. And I think we need to stop, or we need to find ways to make that message more clear. So I appreciate you saying that.
Well, not just that, but the pathologization of sexual health, because you enjoying a safe sex life is part of your overall health and wellness. Like, it's not separate from your general health, because the last time I checked, we were all sexual beings. Regardless of who you mess with or when you mess with them, you're going to have some sex. And if you're not having sex, that's also a problem. What's going on that you're not feeling comfortable, that you can't have that kind of intimacy? Because we all crave that. We all crave the desire and need for connection with others. As human beings, we were never meant to be alone. And so whether that's with the same partner or different partners, polyamory, if you choose to be mutually monogamous, if you don't choose to be mutually monogamous, regardless of how your sex life looks, you need to know that you can do it safely and enjoy it without the fear of thinking, oh my gosh, I don't know if my partner has something that they may give to me, or, oh my goodness, we haven't had that conversation about negotiation of barrier methods. I don't know how to bring up that, part of the conversation, especially when we're in the heat of the moment. And I'm, wanting to be with this person, but I also want to be with this person safely.
Right. So you mentioned one of the methods that we have for prevention is like a pharmacological agent tool PrEP, right? Pre-exposure prophylaxis. What's the biggest myth you hear about Black women and PrEP?
That we don't need it. And that, oh, honey, you don't need that. You're not a gay man. You're not out here in these streets. Like you only have the one partner. Do you know how many times I have seen new HIV diagnoses in women who are in a long-term monogamous relationship and have no idea that their partner has stepped out on them, or that their partner is secretly engaging with other male partners, and that was never part of the conversation. And now that they're testing for their health and wellness, that's when they're finding out that they have this new diagnosis, which is life-changing. And that is what is so disturbing to me, is that we're seeing healthcare professionals like you and myself that are actively being told this is not for you, which I do not understand. If I come in and I tell you that I want something for my health and my wellness, and I've done my own research, you should not question that. You shouldn't read me the riot act and tell me, oh, well, if you're not engaging in these types of behaviors, then you shouldn't need that. No, everybody needs to have access to prevention. Whatever your sexual life looks like, we should not be shamed and blamed for wanting to take control of our health. And that, I think, is the misnomer that we see a lot of times with Black women, because you see that we were being hypersexualized as youth. Now that we're older, it's like, oh, honey, you don't need that. You're fine.
Yeah, I think that's a huge part of the problem, right? Is the community doesn't necessarily know that it's for them. And then when they do, then healthcare providers think that only people who is high risk should be receiving.
But what is high risk? Like, if you're having sex with someone who has an unknown status, that's risk.
Right.
Like, I don't have to be, engaging in chemsex or, transactional sex for it to be quote unquote risky. Anytime I have a new encounter with a new partner and I don't know their status, that's potentially a risk for me.
And that's something that we really want to help providers understand. Let's back up a little bit. Why do you think providers struggle to even have the conversation in general about sexual health with folks?
Because they're not comfortable with their own sexual health. Why would you want to have a conversation with somebody who doesn't even seem like they're comfortable with their own sexuality, let alone your sexuality?
Yeah.
So and part of that is the lack of communications trainings in allied health professional schools. We do not teach how to have culturally competent conversations with our patients, and definitely don't have training around how we have good sexual health conversations. I know we talked about the 6 Ps and the 7th P and the 8th P now, which I absolutely freaking love. But that is something where I think if we make it easy for healthcare professionals to incorporate it into their normal dialogue, it would be much easier for them. But because we're not actively teaching them those types of techniques and motivational interviewing type skills, we are doing our healthcare professionals a disservice, because when they do have a patient in front of them that is asking for that type of assistance, they don't know what to do because they've never been presented with that type of scenario. So the first thing that they think about is they actually rely on their own implicit bias, which is that HIV is a disease of gay men and non-people of color. And if it is a person of color, that person is promiscuous, or they're using IV drugs, or they've somehow put themselves in a situation where they quote unquote deserve to have that diagnosis, right? Like, that's the misnomer. That's the implicit bias that we see, because we're not teaching the skills that they need to really be able to appropriately manage those types of conversations when they're presented with it in the clinic setting.
And for listeners out there, most of you know that my primary job now is nursing academia, teaching and nurse practitioner programs. And so whenever I teach this content, because I'm one of the few that do, whenever I teach this content, I start with this quote of, it's often easier to have sex than it is to talk about it.
Ooh, honey, can we just take a moment for that? Oh my gosh, I am totally stealing that.
Yeah, and I'll send it to you too. But
Please do.
so important because if you don't talk about it, if you're not comfortable having these conversations, then your patients become uncomfortable or feel like the door is closed.
Honey, they smell blood in the water. You start acting all like itchy, like they're gonna be like, I'm not telling them nothing.
And so
your patients will sense it from you
immediately, and then they close off.
And then it's like, boop.
Yeah.
Now I'm a clam.
You talked about implicit biases and those kind of things. What specific assumptions do you think providers and sometimes even Black women make about themselves, right, as it relates to vulnerability or risk?
Part of it, I think, is that we're framing the conversation around risk versus reasons, right? We're not, like, for me, when you're telling me a risk factor and I don't identify with that risk factor, it doesn't resonate with me. But if you tell me I can have the sex life I've always wanted because I can be free to have sex with whoever I want and not have to worry about the potential for contracting an infection, that to me, that's a great reason for me to want to be on prevention, right? Like, I'm taking control of my own health and wellness, and I don't have to rely on anyone else for them to decide something for my health. So I think that's part of it too, is that, like, it's the autonomy portion of it where it's like, I can make these decisions for myself. And then also the other thing that I see often is sort of this lack of just awareness around need for health education and health awareness around sexually transmitted infections in the Black community because of, talk about like people being on the down low, the fact that it's much more associated with folks that are non-heterosexual and are not in, relationships where it's a male and a female. You often see this in same gender loving relationships. And I think the direct to consumer advertising has focused so much on same sex partnerships and risk of HIV around same sex partnerships that those of us in the heterosexual community feel left out, and we don't see ourselves in that direct communication. So therefore, when we start having these conversations around prevention, we don't see ourselves, and therefore we don't ask the questions that we really need to in order to take the best advice from our healthcare professionals, because we don't even think that we're part of the conversation.
Yeah. And this is for the marketing folks out there. I do a lot of community engaged work, and even now you see these commercials around PrEP now, and the feedback that I'm getting from Black women in the community are, I thought those were trans women. And I'm like, no, those women aren't trans. And they are.
I was going to say that, but you beat me to the punch. I was like, yes, the communication, but they think they're trans women. They don't think they're biological females, and they're like very offended by it,
There's still this disconnect that I'm not exactly sure how marketing can overcome it, but they dug themselves in such a deep hole around PrEP and HIV prevention that it's going to be difficult for them to dig themselves out. Now, in terms of providers, right? So in routine healthcare, because you talked about just instead of women asking for it, what does it look like for providers to make it a part of just routine preventative maintenance care?
Well, first of all, I think it needs to be part of all wellness checks. And so we talked about the P's, right? And so for those of you in the audience who don't know, there is a list of things that we typically will talk about with our patients, and they start with P. So practices, partners, pregnancy status, previous STI history, and then pride, which is the newest P that has come out. And then I believe that you have some new Ps that you've added to your list that you can talk about as well. But I think it's a really great way to start the conversation. I often start a conversation with, how do you enjoy sex, right? Mm-hmm. Again, really bringing down the pathologizing of it and making it, quote unquote, a disease state, and making it more about like pleasure, because ultimately we want people to have pleasurable sex lives and not to be concerned about getting an infection from a new encounter. I think when we incorporate that into our general health and wellness, it also helps us to make sure that we are meeting CDC recommendations around who should be tested and how often folks should be tested. It should be part of every annual health screening and women's well check, as well as, that pelvic exam to check to make sure that there's no lesions, ulcerations, or any changes in your menstruation or your vaginal integrity. Those kinds of things, it should be talked about, because ultimately we want women in every stage of life to be able to enjoy sex, not just in their teenage and young adult time, but all the way up through, into our golden years. I just recently, I work for UCSF's National Clinician Consultation Center, and I was on a call and had a client that was calling about a new diagnosis, and it was a woman, African-American woman in her 70s, new diagnosis, HIV positive, Black woman. Like, what is happening? That this is right? Had never tested for HIV, had multiple months of delay diagnosis because they never thought to test for HIV, had all of these issues, recurrent bacterial vaginosis, had all of these complaints, was having all of these issues. And finally someone was like, let's just throw in an HIV test just for good measure. Came back positive. Wow. But this is not the exception. This is what's happening right now. This is not like a one-off. And it's because of lack of health literacy and lack of perceived risk within the Black population. And then also the fact that we don't have healthcare professionals that are actively asking about sexual health and wellness during their times of non-acute care visits, because we're seeing patients so much for acute care, we're forgetting all of the preventative care stuff, because when they do come in for a well visit, you only have 15 minutes.
Right. And you're trying to sneak in all of this other stuff, and
so many things.
Yeah. But it's important, and you have to have it, because someone having delayed diagnosis, it should not be happening in 2026.
No, ma'am.
Yeah. So once we get to actual pharmacological methods, PrEP, what role can pharmacists play in expanding access to PrEP?
Well, one of the things that I love about being a pharmacist is that we are so accessible. The average patient has 20 touch points a year with their pharmacy or their pharmacist. Mm-hmm. And so that's so many opportunities for us to engage with the patient around preventative care and health and wellness. And so one of those 20 touch points, I am definitely going to be asking about sexual wellness, especially if we've got somebody who's coming in for treatment for sexually transmitted infections, if they're asking about barrier methods, or if they're asking about things like contraceptives and Plan B, that means that they're engaging in sexual encounters without a barrier method. The same thing that causes STIs also cause pregnancy. So we should be having those conversations actively with women of reproductive age. And so as a pharmacist, it's wonderful because a lot of states are now adopting the ability for pharmacists to be able to prescribe PEP and PrEP without a prescription from another healthcare professional, which is really great for access for folks who may not have a primary care provider. There's still a large percentage of people in this country who do not have a primary care provider. We know a lot of folks forgo having regular health insurance after the changes in the subsidies from the Affordable Care Act that were not implemented last year with the big, beautiful bill. And so we're just seeing a lot of changes. And so access at the pharmacy is really a fantastic option for folks who are in resource limited areas, as well as the fact that we have people who work jobs that are at the same time that their primary care office is open. So pharmacies offer alternative hours, such as evenings and weekends, that are often more convenient for patients to be able to see someone and actually be able to have a meaningful conversation that isn't timing out after 10 minutes.
Exactly. So I love all of that. And it's working in partnership with
public health, primary care, OBGYNs, my nurse practitioner colleagues, my physician assistant colleagues. It is all about collaboration. It takes a village.
It really does. And if one of the big complaints, as you mentioned earlier, is 15-minute visits, like Okay, I don't have a lot of time to go through this with you, but I know Dr. Madison, I'm going to send you to that pharmacy. I don't care where you normally go. You're going to this pharmacy, so you
Yeah,
have time
no,
to go.
but that's the kind of collaboration that we love, because ultimately, if it is coming from both of us,
Right.
right, not just the provider, not just the clinician that prescribes it, but also the pharmacy is on board. Now you've got two sources of a recommendation where you see patients fulfilling that prescription. So another approximately 30% of all prescriptions are abandoned. So that means that they're prescribed and never picked up. So if you don't have that additional like person that patient trusts, you can often see something being prescribed but never taken. And so I've had instances where I've had patients where we've sent them to the pharmacy to get PrEP, and then they're coming into the clinic asking for PEP. And I'm saying, wait a minute, what happened? And they're like, oh, well, I never picked that up. It was too expensive. Or when the pharmacy told me how much it was, I decided not to pick it up, not realizing that there's patient assistance programs that they can get that will get the copay cost down to, in some cases, $0. Right. And so it takes everyone to educate the patient so that you're not seeing people fall through the cracks where they are prescribed the medication, but then they never pick it up. And so medications don't work if you don't actually take them.
Imagine that. Right. All right. So we're going to switch now to our rapid fire sexual health edition. Okay.
Okay. Am I allowed to say more than one word, or is it just has to be a quick answer?
Well, just a quick answer.
Okay.
One thing providers should stop assuming about patients' sexual health.
That they know everything about everybody's sex lives.
Okay. One question patients should feel comfortable asking their provider.
That they request an HIV screening.
One thing people assume about who needs PrEP that isn't true.
That it's only for same gender loving partnerships and not for heterosexual ones.
One message you want Black women to hear about protecting themselves.
Honey, you are the person that you have been waiting for. Nobody's going to protect you but you.
The end. Okay. One thing
like the end.
One thing pharmacists wish patients knew they could ask them.
That they could help them be able to get their medications paid for. I think a lot of times it's sticker shock. And so the first response is, oh, I'm not going to pick that up because it's too expensive, versus saying, would it be possible for you to maybe look into some patient assistance programs? Or would you mind checking services like GoodRx or Cover My Meds or Single Care to see if I can get a discount? Because I really want to take this medication, but I can't, it's currently financially prohibitive for me. Is there a way that we can maybe work with my insurance, or is there something else that's covered? Can you help me to, work with my prescriber so that I can find something that is a good option for me that can be prescribed, but is in a financial category that is something that I can afford?
Love that. And I feel like that was our last rapid fire.
Yeah.
One of, I know in my pharmacy that I go to, they don't automatically ask me that, but I've had other pharmacies that I have gone to that have said, hey, I already ran it through GoodRx. Here's the price, blah, 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 blah. So I do think, or what do you suggest for people whose pharmacy or pharmacist does not automatically do that for them, or is not receptive when they ask?
Find another pharmacy. And ultimately understanding that depending on the type of pharmacy that you go to, you're going to get different levels of service. Yeah. Not that you're going to get different levels of care, right? Your pharmacist is the same wherever you go, but their workload may prohibit their ability to give you that white glove concierge service, where they can really dive deep and do those things like go in and do the patient assistance program for you, or try to run it through a discount coupon. And the bigger box stores, they are much more limited in the amount of time that they have to do those kinds of things. So if you're at like a regional pharmacy or like a grocery store pharmacy or an independent pharmacy or a specialty pharmacy, they are much more likely to be able to give you that really like individual care, really understand like what your individual financial needs are, your insurance coverage. They're going to have more time to do that educational piece, not just the actual dispensing piece. And so I really do think that people, depending on what their needs are, if you want a pharmacy that's open 24 hours and has a drive-through, big box is your friend, right? Because they're going to have the most amount of hours, but they're not going to have the amount of time to spend with you individually. So if you want that kind of individual service, you are going to have to need to go to a different type of pharmacy.
Yes, I love that. Thank you, thank you, thank you. And that's a really good way to close us out, but also for you guys to think about how you decide, it's just like healthcare, right? You choose your healthcare provider. You need to be choosing your pharmacist too, and not it. I know for some people, you have to go what's closest, right? You have to go.
Yeah, no, I mean, most people live within 5 miles of a pharmacy, but if that pharmacy is not meeting your needs, you really should go to a different.
Well, thank you, Dr. Madison, for joining us today. It's been a pleasure. We learned a lot. We're gonna check out our pharmacies the way we check out our providers.
Yeah, you got to do what you got to do. And one thing I do want to leave the audience with is this: prep care is not specialty care. It's everybody care.
Facts. You don't need a specialist. Anybody should be able to do it. And so the same goes true, I think, for healthcare providers or primary care. If your primary care provider is not offering you prep or just having sexual health conversations with you, you need a new provider. Okay. Now, this has been your health check-in with CRxOWN Talks. If you love this, follow us, like, share, so somebody else who needs to hear it. Subscribe wherever you get your podcast medicine. Consider yourselves Black, healthy, and crowned.